All right, so welcome to today's training on Medicare. This is the first, what we're really starting off here is getting ready for the annual, open enrollment for Medicare starting in October, but this is that lead up to it, and we're going to do a whole series of training. Watch the training calendar. Most everything is given at least twice. The whole point being is I am trying to make it fit your schedule rather than making you fit mine. So I'm trying to get a couple of different options on being able to get the training. Okay. So today, what we're really going to be talking about is kind of that introduction into Medicare. Okay. I'm assuming that y'all have not are not currently selling Medicare, and this is going to give you that look at the market, and you can hopefully help you decide whether or not you should get into it at all. Okay. And I think that it's just a really excellent market and place to get into. And I'm going to hopefully answer this question here for you today. Now, Medicare does require some effort on your part, and I'm hoping to show you that that effort would be well worth it. I'm also going to give you a couple of different paths to get there. Okay, and as we go through it, I'll take on your questions, and we'll be able to see exactly what's going to work for you. Okay, let me start off with exactly what is Medicare. Because when I say here that it's a federal insurance program, understand that once you turn 65 and you start your Medicare, there are no other options. Okay, now there's a few people that are going to be able to stay with their ACA plan because they're just not eligible for Medicare. And there's going to be some people that stay working and they're going to have that plan at work. But when I talk about those who are, going out, they're not at work anymore, and they want to get some kind of medical insurance, there is no other option. Okay? It's Medicare or not, right? And once you're Medicare eligible, you can no longer buy that, government subsidized ACA plan. And I get a lot of complaint from people about that, right? I mean, because that was a great deal if you were a fully subsidized plan. So there's a few things that'll put you on Medicare early, like certain disabilities, one of them being like end-stage renal disease, that will get you on Medicare right off. Kind of stole this slide, but I really liked it because this is our primary customer out there right now. That's that baby boomer, right? People that were born between 1946 and 1965. If you were born in 46, you started, that group started turning 65 back in 2011. And they are going to be just the largest group out there. Right? This is just a huge numbers of people coming in, and they're much different than the past generations. Many of these people plan to phase into retirement. They plan to work past 65. They've got backup plans, right? That say that if they are forced into retirement, they've got another job that they're going to want to go do. Okay. They want to keep those benefits because as we learn more about Medicare and the cost associated with it, they wanted to stay with that plan at work, right? So that's a pretty savvy group of people that are coming into it. Now, they are also turning 65 at the rate of 10 to 12,000 a day, okay? That is just huge numbers, right? People that are going to be needing our help. I don't know how else to say it. 10 to 12,000 a day. Okay, so this kind of breaks it down. Okay, 156 an hour, 3,756 a day, right? 108,000 a month, 1.7 million a year. I mean, those are just huge numbers of people that need some kind of insurance, and this is expected to continue until at least 2030. So let's kind of break down that market for you a little bit. We got about well, we had COVID, so I don't know exactly how many are remaining unemployed, but look at about 175 million people are all out there working and paying into Medicare. And there's only less than 60 million people on Medicare. And as we divide that population down and take a look at it, we're going to see that about 1/3 have a plan from work. And you know who that usually is? These are going to be union people who are in unions, government employees, and by that I really mean they're going to be that state and local government people. Okay, very few big businesses still have the employer-sponsored plan once you go into Medicare, right? And you're still required to get your A and B, which we'll talk about here in a moment. And that is not all that secured in there, because that's a dwindling sector, and they're moving over into the other sectors. In 2017, the city of Chicago, this is just an example that I know of, dropped the promised Medicare, medical services to the retired police and fire. Okay, so all those people who had were counting on their retirement covering that extra bit, the city backed out, reneged, welched on it, right? As a budget cost saving measure. They just didn't have the money for it. And you were starting to see that in more and more companies. Medicaid. Now, people on Medicaid, those are our customers. We have special plans for them that are in the Medicare world. And we are literally going to market to those people. Then you see those that already have a Medicare Advantage plan. Well, I can tell you statistically that 1/4 of them are going to change that plan every year. And if you handle it right, you're going to be, once you establish them as a customer, and you make sure that I always call all of my customers at least quarterly. And I'm going to tell you that 90 to 95% of the time, I never even talk to them. I simply leave them a message. But I want my name to be the name that pops up when they think about Medicare. Okay, when they want. So if they want to change the plan, they're going to call me, and I'm going to do that change for them, and they're going to be my customer for life. Then there's those in Medigap. I mean, that's still 17% are using that, and that is a great plan. And we'll talk later about where that's the appropriate plan. And to top it off, there's 10% out there of all the people on Medicare, not just those that are turning 65, that don't have anything at all, right? And they're available right now. I mean, we can help them, and we can put them into a plan. So there's just so much opportunity here in Medicare. The commissions, okay, they call it street commissions because regardless of what carrier, they all pay the same. Now there's a national average of $539, okay, is the commission when you sell a plan to somebody that's new to Medicare. I'm going to break that down a little bit for you. Now I said that's the national average. They're actually higher in California and New Jersey. They pay more than that. And the ones that pay less than that are the U.S. territories. I don't know if anybody's selling in Guam, Puerto Rico, Virgin Islands, but their commission is a little bit less there. But then, like I said, the national average about $534, $39. It's divided into actually 2 payments. Okay, one of them is going to be prorated. The only time you would see that full 539 is if you sold a Medicare Advantage plan to somebody in January that was new to Medicare, because there's two parts to that commission. $270 of that is going to be prorated based on what time of year you sold it to them. You sold it in January, you get the full 270. You sell it to them in July, and you get half of that, right? It's going to just be prorated to the year. The other $269 is what you get for educating that customer about Medicare and how it works. And you put them in the plan. When you follow all the rules, you had to totally educate that customer on Medicare. And you get compensated for that. An initial sale of a plan is probably going to take you about an hour at least. Okay, so that's still not bad pay for an hour's worth of work. Now, when they renew that plan, and let me tell you, these plans renew, if that customer does nothing, that plan renews. In order for it to not renew, the customer has to take some sort of action. And on that renewal, I get $270. And for the life of that customer in that plan is going to be that $270. Now, if I put them into a different plan, I don't get the full 539 again. I would only get that 270 for the new plan that I put them into. But I'm going to get that for the rest of their lifetime as long as I remain certified in Medicare. Okay? So let's talk about what that means. Okay. I put together this chart and that first column that says if I just did one app a month, I had, looking at my book of business, I had one person each month that I was able to put into Medicare. Okay. I would make about $5,000 that first year. But I'm going to make that 5,000 plus the renewals in the next year, and then 5,000 plus the renewals, et cetera, as we go on, so that 10 years from now, I am literally making $51,000 for waking up in the morning, right? All I have to do is maintain my certification, and that customer is my customer, and I'm making that commission just month after month after month, okay? So these are annual amounts, but on those renewals, they're actually paid out monthly. So if I did 2 per month, right, 25 a year, right, roughly 2 a month, you can see I just double what I did literally that first time, okay, for the first year. But it's going to be quite a bit more because it's, you know, I mean, the numbers are 10 and 25, they're not, you know, 10 and 20. But you get the picture there. And if I wanted to go all out and be that real go-getter and do 100 apps a year, I'm not going to get rich quick. I'm going to get rich slow, but I'm going to get rich. Look at that, 10 years of doing that, I'll be getting $500,000 a year if I never sold another plan. Okay, so that's what I'm saying. It's not get rich quick, it's get rich slow. If I do that 100, you know, apps a year, I am literally working like nobody else will, so I can live like nobody else can, because that is a good annual salary. So now, when it gets to Medicare, there's 4 parts to it, and I'm just going to put that whole slide up, and we'll just discuss what these 4 parts are, so that they'll kind of make sense. Okay. Part A. Part A only covers you when you're in the hospital. And I don't mean there for observation or there for an appointment. When you are an inpatient in the hospital, Part A covers that. When I go, and if I'm there for observation, or if I have any of that physician or with a, you know, medical costs, that comes under Part B. And it's important that we understand the differences there. Between an inpatient in the hospital and what's covered there, and that's going to be Part A, and then because Part A has its own deductible, you know, $1,464 per benefit period. Like I said, once you've explained all this to customers, we don't sell these plans. We give them education, and people want the plans. Okay. Part A is done by benefit period. Benefit period starts with being admitted to the hospital and ends when you've been discharged and have been out of the hospital for 60 days. Okay, so with each benefit period, I have a deductible that I pay, $1,464. Worst case scenario, I could pay that 5 times in 1 year. Okay? It's not a once a year, it's once a benefit period. Part B has an annual deductible of $204. Okay, one payment, and then it becomes simply 80/20. If I could find a doctor that would see me for $100, Medicare would pay 80 and I would pay 20, and that 20 is going to be collected at time of service, right? Also keep in mind, if that surgery was going to cost me $100,000, they would want that $20,000 at time of service. Part C is what we want to sell people. Okay, that's that Medicare Advantage plan. It just simply takes that Part A and Part B and wraps it up into a private plan sold by a private insurance company that makes my Medicare mimic just that major medical, right? I have a co-payment when I go to the doctor, a co-payment if I'm admitted to the hospital, co-payment if I go to the emergency room, co-payment if I get an x-ray. Whatever I do, I've got some kind of little co-payment that goes with it. Now, in order to get Part C, I have to already have A and B. All that's going to change is that the federal government that pays the bill, or is it going to be my insurance company that pays the bill? Okay, that's the only difference. And then there's Part D. Part D is the newest part of Medicare, came about in 2006. It is brand new in Medicare years, right? And that is your prescription drug coverage. Okay. Unlike A and B, where I can buy that and get it from the federal government if I wanted to, Part D does not have a federal government prescription drug plan. All the federal government does is describes the outline of what the plan must do. It's going to say things like, you can have a deductible no more than $445, things like that. They're going to describe the plan and what it must contain, and maximums and minimum stuff. Okay? No minimums, usually just maximums. So I can be better than the government model, but I cannot be less than the government model. Okay, so let's break down that Part A a little bit. These are what is covered under Part A. Like I said, you had to be an inpatient in the hospital. So that meant that you were actually admitted. And then they say for inpatient care in a skilled nursing facility. Well, what goes with that, in order to qualify to go to a skilled nursing facility under Medicare, I had to have 3 days as an inpatient in the hospital. Okay? And when they say that, they don't mean I was there for 2.5 days. I was literally there for 72 hours. Okay? And they're gonna, if it's less than 72 hours, less than 3 days, then I would not qualify for the skilled nursing facility. Okay? And when I go to the skilled nursing facility, Medicare is going to pay 100% of the first 20 days. And then on day 21 through day 100, I'm going to have a copay of $180. Okay, so, but Medicare is only going to cover me in the skilled nursing facility for a maximum of 100 days. Beyond 100, I pay the full bill. Now, maybe I didn't qualify for that skilled nursing facility. Remember, I had to have 3 days hospital care first? Well, in that case, I'm going to get the home health care. So I always like to use as an example of the stroke patient, because it's just easier to see here. So a person has a stroke, they're rushed to the hospital, they get them stabilized. It usually takes a few days, so you're there more than likely going to span that 3 days of as an inpatient. And then you're going to go to the skilled nursing facility. They're going to start doing all that physical therapy and speech therapy and that sort of thing. So that's a pretty good scenario that got me there. But maybe it was a really light stroke, and all I really needed, I didn't even get my 3 days in the hospital and I got sent home, but I really have that need for physical therapy. Well, the doctor can set that up, but it now has to have a treatment plan, a very specific plan, and it has to have, a treatment plan. It's going to have to be results. It has to be time bound, and so the doctor is going to say, Mr. Smith needs 6 weeks of physical therapy. Okay, so that physical therapist hops in their car, drives over to Mr. Smith's house, and provides that physical therapy, once a day or whatever is called for in the prescription. And that's going to be at zero cost. Medicare is going to pick up that full bill for the home health care. And then the last thing that's covered under Part A is going to be hospice. So if it's been determined that you've got 6 months or less of life remaining, you're going to qualify for hospice. Medicare is going to pick up that bill. They're going to pick up some really minor charges on drugs and stuff like that. You'll still have, but for the most part, your time is going to be fully covered by Medicare. Some drawbacks. One, any effort to cure your problem will now stop. Hospice does not work on continuing your therapy for cancer, like radiation or chemotherapy. None of that. It all stops. All they're going to try to do is manage your pain and keep you comfortable, for the end of life, and a lot of counseling for both you and your family. That's all going to be provided there. So anyway, that's Part A of Medicare. So let's move on over here to Part B. And Part B is going to be that other part of the services, less the prescription drug, right? Because prescription drugs are going to be covered by Part D. But so that's going to be your doctor visits, any outpatient. I mean, even surgery is done on outpatient these days. Medical equipment, think wheelchairs, CPAP machine, diabetic meter, x-rays, lab tests. Also, it's going to include those things like chemotherapy, radiation treatments, all physical therapy. All of that's going to, kind of fall under that outpatient services, your ambulance ride, just about anything that you can think of that they would provide is going to fall under Part B. Okay. The thing about Part B is once you've met your deductible, that $204, it's now an 80-20 plan. You go to the doctor. If you could find one that would see you for $100, you would go there. They would bill Medicare for $80, and they would present you a bill at time of service for the $20. And likewise, if that surgery was $100,000, they would send $80,000 off to Medicare, but they would be reaching their hand out for that $20,000 at time of service. Unless you made some other kind of arrangement, they want that money right then and there. So then here comes in Part C. Now, to get Part C, I have to have A and B. Okay, and that's not going to go away. I'm always going to have to pay for my A and B. A may be free, okay, but I'm going to have to pay at least for that Part B. Now, Medicare Advantage plans, which we will call Part C, what we've really done is we've shifted who pays the bill. It was Health and Human Services handling that, right? Medicare. Now it's going to be the private insurance company. So you always wonder how that happens is as you sign up for a Part C plan, Health and Human Services pays the insurance company now, right? They get some money from the government for your health care. Now they're going to turn around and take your health care, and it's going to start to mimic the standard plan that you've always had, with an HMO or a PPO plan. And you're just going to have your co-pays and stuff like that. But it completely replaces that original Medicare. If original Medicare covered it, so does your HI, so does your Part C. Like I said, it can be an HMO or a PPO, but you can't be both. Okay, you can't have both original Medicare and an Advantage plan. It's going to be one or the other. And that Advantage plan is normally going to include that Part D, prescription drug coverage. There are cases where you may not want that. And the biggest example I always would throw out would be like a veteran, right? Where they can get their drugs from the VA. They're not going to want to buy a separate plan. Okay? And, you can pull the VA and Medicare out of the library and take a look at how that works too. So Part D, that's your prescription drugs. Like I said, it can be done a number of ways. It can be part of your MAPD, okay, where they've combined your A and B with Part D, or it can be a standalone prescription drug plan. And that's going to be for somebody that went with like a Medicare Medigap plan. Okay, would want to go that way. So let's just look at the picture here. So we have A and B, also referred to as original Medicare. And then you have to have that in all cases. You can't move on into any other coverage without it. The way they break that down would they say for Part C, you must have A and B. And for Part D, you have to have A or B. Now, there are reasons why one would just have A or just have B. Not that we're going to talk about that today, but there are reasons where that could be in there. So to get the prescription drug coverage, you only need to have one of them. But to get the Medicare Advantage plan, you have to have both. Yeah. So let me show you kind of your paths to getting coverage. So in Medicare, these are your choices, okay? Let's just take the path on the left first. So I get my original Medicare. I have to have that no matter which path I take. So in this case, I'm going to get the original Medicare, but I am not going to go for an Advantage plan. I'm going to simply decide, do I need to get a Part D plan? My advice to anyone who's trying to make that decision is yes, you do. Unless you're a member of one of the, like a religious group that doesn't believe in medication or something like that, they could do without. Or if you're getting that covered by somebody else, like the VA, or if you're a Native American and you want to get, and it's covered by your tribal health, those are some other reasons why you wouldn't want to get Part D. But if you decide later to get Part D, there's a penalty for not getting it when you should have at the beginning of Medicare. Okay, so then you can decide, do you want to supplement that Medicare? Okay, if I want, if I have just the original, again, that path on the left, I can now get a Medigap plan. And they'll fill in the gaps there in Part A and Part B. And by filling that gaps, I mean they'll pay those deductibles and co-pays, that 20% that was not covered by Medicare. Or my other alternative is to get the Advantage plan. I still have to pay for my Part B premium unless somebody else is paying for it, like in the case of Medicaid. Okay? And I have to have my Part A. And when it comes to Part D, it's going to be combined in there. It's going to be part of my plan. And that's the end. I can't get a Medicare's Medigap plan to pay my co-pays of a Medicare Advantage plan. You can't do that. It's going to be one or the other, no both. So we're going to now take a closer look at that Medicare Advantage plan. Okay. Now, Medicare Advantages are available almost, and I stress almost, anywhere in the country. However, like a private, regular private, the coverage may be limited in a particular geographic area or subject to, decreased out-of-network coverage. And these things, sometimes they're going to offer extra benefits. If you live in a large metropolitan area where there's like a lot of competition, these plans are going to try to differentiate themselves in this area of supplemental coverage in there. They're going to beef up their dental, their vision. They're going to include things like gym memberships, maybe over-the-counter drug coverage. A lot of extras can be packed in there. Typically, though, that's going to be in a large metropolitan area. For those, if you live on the West Coast, you can kind of, pretty familiar with the I-5 corridor, runs from Mexico to Canada. As you down in Southern California, I mean, huge, densely populated. There's probably 100 plans there in the LA area, right? But as you come up and you get up there into, between Bakersfield and Fresno, very little plans in there. And then as you come back up into the Bay Area and Sacramento, you start to see a lot of different plans available. But once you go north of Sacramento and to the Oregon border, there could be areas with no Advantage plans at all. Okay? And you get into Oregon, maybe they're at the southern end, Medford, there's some plans in there. They kind of disappear until you get up into the, Salem, Portland area. You start to see a lot of plans again. Vancouver, Washington, but once you get north of Vancouver and still south of Tacoma, Seattle, you may not have any plans at all in there, especially over on the coast. Okay? So that's what I mean by, there's got to be enough in there for them to be able to build a network. And while these plans are in all 50 states, doesn't mean they're in all counties of all 50 states. And like I said, that's what I was saying, in areas that have higher competition, you see more comprehensive benefits. And in some locations, the cost of the plan may go up, right? There can only be one or two plans, and they can be $40, $50 a month, tacked onto them, just so that they can, make them available in those areas. So all in all, if I compared original Medicare to being on a Medicare Advantage plan, starting there, if I stay on original Medicare, my enrollment is typically going to be automatic when I turn 65. If I'm drawing Social Security, it happens automatically. If I stay working and I'm in a plan at work beyond 65, I'm going to have to actually apply for Medicare, but for the most part, it's going to be automatic. About 93% of all the doctors, and that should really read non-pediatric, but about 93% though are going to be taking Medicare. Medicare itself does not cover dental, vision, or hearing. In my mind, that is nothing more than sales opportunity, so no big deal there. Unless you get Part D, original Medicare does not cover prescriptions. We talk about gaps in coverage, and when they say gaps, what they're really talking about is deductibles and copays. So you have that, and you can have some options, like they say, Medigap to cover that. But here's a key thing. You are unlimited in your geographic area of coverage. Now, that has to be in the U.S. or U.S. territories, right? You can't, my Medicare does not work in Mexico or Canada, okay? But you have to be inside the U.S. But they still say unlimited geographic coverage because I can go anywhere in the U.S. I can go to any doctor or any hospital, and they will more than likely, like I said, 93% will be taking Medicare. Now, if I go over to the Medicare Advantage side, I have to enroll. I have to actually take action myself and go out and enroll in a plan. To get the absolute lowest cost, I have to stay inside my network, even in a PPO plan. Okay? However, I may pick up that dental, vision, and hearing care. It's usually going to include the prescription drug coverage. I have smaller gaps in coverage, but I can use hospital indemnity plans to fill that. We'll talk more about that in follow-on training. And I can truly be limited to a geographic area. Again, emergency and urgent care, by definition, must be covered anywhere in the country. But as far as getting regular care, maybe not. Okay. I always like to use the example as I packed up the grandkids and I went to Disneyland. Okay. Suddenly felt like I was getting the sniffles. I can't just go make a doctor's appointment. You know, that I could easily be out of the area, and I either can get my choices become emergency room or urgent care. Right? I can't just make an appointment to go see a doctor. So that's kind of the drawback to the Advantage plan. So in order to sell these plans, these Medicare Advantage, because that's really what we're talking about selling, a little bit on the prescription drug plans, but you know, they're not as much as the Medicare Advantage is going to require me to do what they call is AHIP. Now, AHIP is just a national trade association, okay? And AHIP has a cost, okay? They're going to charge you $175. You can easily go through a carrier. I usually use Humana myself, and they'll pay $50 of that, leaving me with an out-of-pocket of $125 in order to complete my AHIP. Now, AHIP is going to be required by literally let's see, that comes up later, but it's going to literally be required by all the companies to show that I have, gotten certified in Medicare, right? So they're going to do that initial certification for me. I'm also going to have to certify with each carrier, but they're not going to charge me for it, okay? But that initial one will, and every company accepts AHIP. And everybody requires AHIP except for United Healthcare. So I'm going to talk about United in much more detail for those who want to just maybe dip their toes into Medicare and not take that full plunge. Okay? And there's going to be a choice in there on whether or not you want CE credits for the time you spent there. Normally don't recommend them. They're kind of expensive for the cost. I mean, I can pay $60 and get a whole package of 24 credits, right? Or I can pay this about the same amount of money and only pick up about 5 or 6 credits from AHIP. So I find them very expensive and don't recommend them. Although I will be the first to admit that time is money, and there can be a case where I've got more money than time. All right, so this is what the website looks like. You just www.ahip.com, and that'll take you in here. If you've done it before, you'd have a username and password, but for most of us, we're going to register for the first time and create an account. And from there, they're just going to basically charge you, and they're going to have you go through the course, right? And it's mostly going to be about marketing and marketing rules and stuff like that. They're going to assume kind of a base knowledge of Medicare, but they're going to talk about all the rules associated with selling Medicare. I would have you look at the training calendar. Everything is brought to you a couple of times. What we spent today on Part A and Part B, we'll go deep dive in there and probably spend more than an hour on that topic alone, right? Rather than the few minutes I spent kind of describing what they were. And so it actually launches next week. Okay, I do this training more than just this time of year, so that's why I would say that pushing off doing AHIP till June later on here in the slide, right? But here's what we're talking about. So everybody except United Healthcare. So if you're new, and I would tell you, like if this was in April or February, I'd be telling you to wait until June. But I give you that option of certifying with United Healthcare, because United Healthcare is not going to require AHIP. So they're going to give you some, a good advantage there. The thing about that is, though, that is a non-transferable. In other words, just because I did it with United Healthcare, it's not going to be accepted by Humana or Aetna or Blue Cross Blue Shield or any other company that you might be interested in selling. So they're all going to require AHIP. So what do you want to sell? In other words, where should you get certified? Okay, I'd look at it this way. There are 3 national carriers, and these guys are going to be in just about every state, not every county, but nationwide. It's going to be United Healthcare, Humana, and Aetna. They're going to have that great presence throughout the country. Now, not all doctors take all 3, and that's why you'd want those. Somebody who's been seeing that primary care doctor for the past 10, 15 years, may be reluctant to change doctors. They've built rapport, they're well established, but that doctor only takes Aetna, or only takes United, or only takes Humana. I mean, and you get into different areas. I'll give you an example. I live there in Portland, Oregon. And where I live, United covers, they cover Providence Health System, and they cover, I think it's Legacy Health System, but they don't cover Adventist. Okay? So if I wanted my doctor and I was all centered around the Adventist health, I would need to either have Humana or Aetna. Just a couple of little things there like that. So you need to know where you're selling and what what is your customer interested in. And then every region has its own particular companies. I'll give you some examples. If my primary sales was in Texas, I would want to also be selling Baylor Scott and White. It's all centered around Baylor University. It covers around 10 or 15 counties in central Texas there, but very popular in that area, right? If I was selling in Florida and I was a Florida resident, I would want to sell Blue Cross Blue Shield of Florida, and it's Florida Blue. Florida Blue does not license or certify to sell in Florida non-resident licenses, right? So you have to have a resident Florida license in order to sell that one there. So, I mean, for people that live in Florida, it's a big deal. Or living out here on the West Coast, down in California, is a company called Scan, right? So they're popular. If I lived in Monterey County or sold in Monterey County, Aspire. It's the only MAPD in Monterey or in that county. That's what I was saying. United, while they're all over in California, they're not in that particular county. So there's a lot of little regional ones that you would probably want to be interested in. For most people, that's going to be like a Cigna, HealthSpring, and a Blue Cross Blue Shield, whether it's Blue Cross Blue Shield or Anthem providing it. Okay, so those are just some regional ones. Now I bring up United in particular because they don't require the AHIP, and if you just wanted to dip your toe into Medicare, be able to sell an MAPD from time to time and a prescription drug plan, especially to pair up with the Medigap plans. United would be the way to go. No HIP certification, no AHIP required. They do have non-resident fees for selling in some states, and be aware of that. But they do have an agent of record program so that if you're the agent of record and some other agent tries to sell them a United plan, you continue to get the commission. Agent successor program. In other words, you can sell your book and have if that agent go with it. They're great on their commissions. They got a great website for doing that stuff. So there's always a lot of good to go with that. So also, because it's Medicare, we need to talk about Medigap plans. And what I like to always point out is that with Medigap, you have to have the original Medicare to begin with. So you have to have A and B. And we're going to you'll see these referred to as Medigap, MedSup, Medicare Supplement. But to avoid any confusion, I like to simply refer to them as Medigap, because your customer is going to consider anything that helps with their Medicare to be a Medicare supplement. It could be an indemnity plan, it could be a cancer critical illness plan. I mean, literally anything that helps, they're going to call that their Medicare supplement. So we want to draw a distinction between that and a Medigap plan as being a specific type. Now, if it's not covered by Medicare, having a Medigap plan is not going to cover it, right? Medicare, for example, does not cover dental, so Medigap is not going to cover dental. Okay. They may provide you with a discount program, but they're not going to give you any kind of medical insurance, because it's very important you understand that they simply, if it's not covered by Medicare, they're not going to pay it, because the way the billing works is the bill goes to Medicare, and anything that Medicare rejects, so will the Medigap plan. So when they say Medicare related costs, they're really talking deductibles and co-insurance. Okay, that's primarily what they're going to be paying. Okay, now these Medigap plans, they are private insurance companies, but they're regulated by Medicare. And so what Medicare has done is created an alpha system from A to N. There's about 10 of them in there. It's not all letters, but there's they're called Plan A, Plan B, Plan C, Plan D, okay? Like that. Not to be confused with Part A and Part B. Okay? But each one is going to have its coverage described by Medicare, and they're going to be able to tell you which one it is. So just thing I always do like to draw that distinction, that a Medicare Part A is not the same as Medigap Plan A. Okay, they're different. Besides, I mean, they're both named A, but they're totally different plans. And remember, the only people that can purchase a Medigap plan must have original Medicare, must not. It's actually illegal if they're on a Medicare Advantage plan to sell them a Medigap plan, or if they're on Medicaid to sell them a Medigap plan. Those are just been determined by CMS as things that are not allowed. Now, typically we think of these as being underwritten, but there is a guarantee issue period. There is a point in time where there are no underwriting or underwriting questions associated with these Medigap plans. It's really tied to your Part B. So when you are enrolled in Part B, and they give you that date, okay, and it's always the first day of the month, right? So if I first became eligible for Part B on July 1st, I would have guarantee issue for the next 6 months, so up until January, right? So I get 6 months where there is no underwriting, no MIB check. I am just, all I got to do is, I think the only differentiation you can put in there is whether or not they smoke, right? Smokers are going to pay a higher rate than a non-smoker, but there's been no medical history in there. Now, after that time period, and the reason they say 65 is because that's when most people get their Part B. But as we saw on that earlier slide, that people in this baby boomer generation have been putting it off and putting it off so that they don't get Part B because they continue to work and stay in that plan at work. And so it guarantee issue actually starts with your Part B and continues for 6 months. Now, if you go beyond the 6 month, then they can go into medical underwriting and they can choose not to accept you. Okay, so keep that in mind that we want to be able to try to enroll during the guarantee issue period. Now, these plans also have annual rate increases. Now, they're just trying to, fill in for inflation, cost of healthcare, and stuff like that. But it's typically based on age, not necessarily, but typically it's based on age. And they'll make those, there's a lot of different calculations that are allowed to be used for how they do it. Can be, geographic areas. It can be all the people in the company. It can be all the people of a certain age in the company, but it has to apply to everybody in that group. They can't single out a person and charge them more. Okay, there's another plan out there that falls under this. I usually recommend that you just stay away from them. And it's called the Medicare Select Plan. And it's going to be listed in there with Medigap. They're going to have their same plans, a Plan G, Plan D, and all of that kind of stuff. The reason we want you to stay away from those is because what drove most people into getting a Medigap was that the fact that there was no network. Now you're in a network. And there are no provisions for going out of network. So if you go out of network, you can have 100% of the bill. Okay. So for that reason, we recommend that you just avoid them entirely. You'll see them, and people will ask you about them when you're quoting. Just stay away from them. They're not worth it. All the reasons for getting a Medigap were that portability, and you've given it up. So here's that alphanumeric chart that kind of shows you all the different plans and what's covered and what's not covered. I really hate this chart. It's just, I just think it's crap. All the plans, these are all of them that are allowed by CMS. And in fact, we don't sell most of them. You see that one there, Plan A there on the left? All it covers is a few things under Part A of Medicare and nothing under Part B. Doesn't even fully cover Part A. But that CMS came out with this rule that said, in order to sell any of these plans, you must have in your repertoire or your portfolio a Plan A. I've never sold one. I don't know. I'm not sure why anybody would want one. I think the only thing about them is that in places where they have under 65, that may be the only plan that's available. For most of the plans, you have to be 65 in order to get them. Okay. But you'll see Plan A would be available. Not that I even want to sell it. To be really honest with you, we sell 3 of these plans. Okay, that's it, just 3 of them. And here's the kind of the way that it goes. Okay, I'd start with Plan G. Plan G is the Cadillac plan of all of these. It used to be Plan F. Plan F is still available. You see it over there on the far right. It literally covered everything. The only thing that Plan G is lacking that Plan F covered is that Part B deductible, the $204. Even when Plan F was considered the Cadillac, I sold very few of them and mostly sold Plan G because what you would find is that you had the $200 deductible, divide that by 12. I don't know exactly what that is, but it's roughly 20 bucks. You would expect that on a monthly payment, Plan G would be $20 less than Plan F. Well, it typically ran about $50 a month, more for Plan F than Plan G. So you were literally paying $30 for them to cover that $20 a month for you. Never made sense. It was always the economically more financially feasible was the G from the beginning. Okay. So anyway, so nowadays G is the Cadillac. Plan F is still available for those who were eligible for Medicare prior to 2020, but it will be medically underwritten if you put them into it. Okay, so there's no guarantee issue into Plan F, and it's only available to people who were eligible for Medicare prior to 1 January of 2020. So we rarely sell it anyway now. So Plan G is our go-to plan. Maybe they look at it and they say, well, gosh, that's just too much money. Okay, my drawback then is to step down to Plan N. Okay, if you look at what's not covered by Plan N, you'd see that it's the Part B deductible, since nobody covers that, and Part B excess charges. So the excess charges under Part B is that when they came out with all those billing codes for Medicare and said, for that doctor visit that I was using in that previous example, we're going to say that Medicare says that's a $100 service, and that they're only going to pay 80% of it, so Medicare pays 80, and you paid 20. Well, okay, well, Plan N covered that. But your doctor said, but I'm better and I'm allowed that 15%, so I'm going to charge, $115. So all my Medigap covered now was the $20, right? That was the 20% there. And they passed on that other 15% to me, right? So I would get billed 15 bucks. So that's what people didn't like about Plan N. Because you can get those little nickel-dime billings that can happen in the form of these excess charges. Okay. Now, here's the thing, though. You want to know your states, know where you're selling, because some states, in particular, I'm going to call out the state of Ohio, passed a law that said excess billing is not allowed in that state. So even though the federal government said that they could charge 15% more, the state government in Ohio said you cannot. So if I'm paying, $20, $30 less for Plan N than I was for Plan G, in the state of Ohio, I'm really getting Plan G, right? Okay, well, there's some other little things that go with Plan N. So let me kind of tell you about those. In Plan N, I pick up 2 copays. On there also. I pick up a $20 copay for a doctor visit. Doesn't care whether it's a primary care physician or a specialist. You see a doctor, there's a $20 copay. The other copay is a $50 copay if you go to the emergency room. Okay? So everything else is going to be covered, but I have a $50 copay under Plan N. So for somebody who rarely goes to the doctor and lives in the state of Ohio, I'm just kind of throwing some caveats in there, you would see that Plan N is really a pretty good plan, right? I'm paying quite quite a bit less per month over Plan G. And with the exception of the co-pays when I do go to the doctor, and if I only go once or twice a year, I've saved quite a bit of money by going to Plan N. So those are my two go-to plans. And my third one is Plan G has a high deductible version. Now that deductible is around $2,500, meaning that I'm responsible solely for, paying that $2,500 before Plan G kicks in. And then once I've spent that, Plan G kicks in and I'm just fully covered, right? I just had to be responsible for the first $2,500. And where I like to use that a lot is I come across those Medicare people that are outside of an open enrollment for an Advantage plan, but want something because they're just so exposed with just original Medicare. I can pick up one of these plans for the neighborhood of $50 a month or so, and then as soon as they're eligible to get into an Advantage plan, I would change them over. Okay, so that's the way I use Plan G a lot. Now there are people out there who prefer to just stay in that; they can afford that deductible, and go with that. A few of the things I always like to keep in mind is that remember that half the country doesn't have $1,000 in the bank. So where's that money going to come from? All right, so moving on here. Okay, I'm just going to give you some final thoughts here to kind of wrap things up. I think I've shown you that Medicare is a pretty good place to be selling, and here's the way I would look at it: is try to remember that original Medicare is managed by the government, and then both Medicare Advantage and Medigap plans are private but subject to Medicare laws, right? So CMS still provides the rules, but they don't pay anything, whereas under original Medicare, they're going to be your provider. Okay. Now, Medigap is designed to fill the holes in original Medicare, in that you cannot combine Advantage and Medigap, okay, one or the other. Okay. Hospital indemnity plans, we're going to have a whole training on that. They're going to cover the holes in either a Medicare Advantage plan or original Medicare. It's just going to be another alternative for original Medicare rather than going into a Medigap plan because they're a bit simpler. Market with education. Once you teach people about how Medicare works, they want the plan, okay? And it's just going to be turned into an affordability issue. And some of those Medicare Advantage plans have zero cost. So always act with integrity, honesty, and consistency, and you'll stay out of trouble. And I think I've shown you that it's a great way to make money and a great way to help people. So, and okay, let's see, that's we're looking at one of the things in Medicare is trying to figure out exactly, I have to look up all your doctors so I can go and look up your doctors with each company. In other words, you tell me you have Dr. Brown, I go to United, I look to see if Dr. Brown's there, I go to Aetna, see if Dr. Brown's there, I go to Humana, see if Dr. Brown's there, et cetera, right? Trying to find out what plans Dr. Brown. There's a couple of places to really shorten that up. One is to use a company called Sunfire, where you put in the doctor and they will, and a zip code, and they'll tell you what plans in that area has that doctor as a member. Or you can also use like eHealth. I wouldn't use that in front of the customer, but if you go to eHealth, they have that same feature where I can put in the zip code, list all the doctors, and they'll tell me what plans in that area or that has that doctor as part of the network. Okay, let's see here. Let me get my computer to work here. 1 Seems to be the hang up here. Okay, this is where I wanted to kind of finish up here, is just trying to give you some people. I'm always asked this question, when do I want to sell an Advantage plan, and when do I want to sell a Medigap? So always, in all cases, we're going to start off with that needs analysis, right? I got to know what particularly they like or dislike about what they've got. I need to know who their doctors are. What are the needs that that customer has? And then I always fall back on the most comprehensive plan that they can afford. Okay? Just given that as the beginning. So Medigap or Advantage. A Medigap, that customer comes in and tells me that money is no object. I want the best plan available. Okay, I will do that for you. It's probably not going to be just a Medigap. It's going to be a Medigap plan, a prescription drug plan, a dental, vision, and hearing plan, and a heart attack, stroke, cancer plan. I'm gonna load you up, right? You tell me that you want the best and money's not a concern. That's what I'm going to give to you. That's going to be my recommendation. Then the next thing that falls into that Medigap is somebody who is now entering Medicare, okay? Because I want them to be in their guarantee issue period. And I know that they've got expensive medical needs. Maybe they've already had a heart attack and got stents put in and all that kind of thing, where that's definitely just going to be an expensive problem. Maybe they've got COPD and they've got a lung transplant in their future. Maybe they're diabetic, right? There's just so many things that go along with diabetes that I am really going to push them towards that Medigap plan, because there's just so many things that go in there. And the other one is going to be, they live in that area that doesn't have any Advantage plans. I don't want them running out there with nothing, just straight Medicare. I mean, your liability is unlimited in there. It's, it's 80-20, but there's no max on that 20%. I mean, you need that transplant or something, you're going to be paying 20% of that cost, right? So that's the other one. They live in an area that doesn't have any Advantage plans. I'm going to go to the Medigap. Now, I may have to, because of affordability, put them in that high deductible plan, but that's going to be far better than nothing at all. I mean, if you got a plan that had an unlimited out of pocket, just straight Medicare, versus a $2,500 deductible. Even if you don't have $2,500 in the bank, you're far better off paying back the $2,500 than the $20,000, right? It's just crazy. And then Medicare Advantage. I tend to like the very healthy to start with. It's hard to convince somebody they should be paying $100, $150 a month for a Plan G, and all they're ever getting is an annual physical, right? I mean, man, is that an expensive physical, right? So they're very healthy. So they may not have any extra money. It may be somebody that's on a very limited income. I could argue that the Medigap still works best for them, right? Because I can give you very predictable costs. I make a monthly payment. I have a $204 a year deductible, and that's it. Everything else is going to be covered. So you tell me you've got no extra money, I can give you some very good stability in that Medigap plan, but you may also be very attractive to that zero premium Medicare Advantage plan that's got a lot of the extras in there. And there are people that simply want those extras. I'm very healthy or not, but I don't want to pay extra for dental and vision and hearing. I want to be able to get some of those over-the-counter drugs at no cost. Right? I want meals provided. I mean, there's transportation. There's so many extras depending on where you live that could make that very attractive. And the other one is maybe they're not poor. I mean, that's probably a bad example. If they were really poor, they'd be on Medicaid, and I'd be putting them in an Advantage anyway. but somebody that's just very conscious of their expenditures, right? They just don't want, I've got, an X amount of money to live on each month. I don't have a job. I'm not working. I'm retired. So it's a fixed income. I just want that predictability. I understand that I have a max out of pocket. I've got the money set aside for that should it happen. I mean, whatever, right? So there's some good arguments for that. So that's kind of what I would look at. Is my guidance as far as which plan and where.